Dr. Parul, who is our chief instructor, will be talking about how we can incorporate the premium IOLs in our practice. And as you know, there are two ways of growing the practice. One is to get more patients. Second is to get more value from the same patient, and also by giving more value to the patient. So that we can do by incorporating the so-called premium IOLs. Parul.
Thank you, Vinay. Thank you, Anchal, for an enlightening talk. I think in a solo practice, everybody comes with a mind frame. Everybody wants premium patients and want to do um, premium segment of lenses, premium surgeries. So I will be talking about that how and why do we need to incorporate these premium lenses in our practice. We all have seen evolution of surgical techniques from ICC, which I started in my residency days, to ECC, to phacoemulsification, and now flex. We also have seen a lot of advancements in technology in terms of peristaltic to venturi, and now we have active fluidics and active century. The lenses have advanced from rigid to foldables to multifocal lenses to torics, and now we have trifocal ERV and EDOF lenses on all these platforms. So the advances in surgical technique has made cataract surgery a refractive surgery, and the goal of refractive procedure is to successfully eliminate the need of prescription glasses with full correction. So why do we need to incorporate these premium lenses? Because I think all of you would agree, and I am a hyperope myself, so I know presbyopia is pain. Now we all know that people are going for early retirement, so 60 is new 40 when people want to do a lot of different activities without any hassle of glasses. We are seeing a lot of cataract in younger population because of steroids, because of multiple lifestyle diseases. There has been explosion of these electronic devices in our life, and we want multifocality. We want to see things clearly at almost all distances. So I think all patients deserve multifocality, and if we are not offering these to our patients, I think we'll be left behind because we all know that our competitors are offering these lenses. So when we talk about the patient wish list, it is kind of non-ending. Every single patient would love to have binocularity, multifocality, a full range of vision without any hassles of glare and halos. So it's not only just 6 by 6, but patients want N6 and continuum of vision also. And the options that we have to offer to our patients are the advanced monofocal lenses, the trifocal lenses, the EDOFs, the ERVs, and toric lenses on all these platforms. Now, why we hesitate in offering these lenses? There are a lot of reasons, but I think the most important reason is the dysphotopsia and glare and halos these lenses bring along. There is loss of contrast because the light distribution is happening to both distance and near segments, and that is why there's loss of contrast, and patients are not too happy about it. And many a times when we tell that this is going to give 100%, actually 100% freedom is a false statement. It does not make you 100% spectacle free. There are times when you would need a spectacle aid to look or read clearly. The number two challenge is that any problems like you have dry eyes, you have residual cylinders, or you land up in refractive surprises. Now, all these areas you are going to have a much more amplified result if you are using these advanced trifocals or multifocal lenses. So, you have to be extra careful when you're dealing with such patients. Definitely, when patient is paying more out of their pocket, the post-operative chair time is more, and you have a lot of dissatisfied patients, and that's what you don't want, because you don't want your patient to be leaving your center, going to some other doctor and cribbing about the results, and unhappy patient about these lenses. And whenever these lenses which are so expensive, we are offering these lenses, so we have to be extra careful, and that is why we always feel that better है कि भाई दूसरा लेंस डाल दो, कौन इतनी हेडेक लेगा पोस्ट ऑपरेटिव पेशेंट को देखने के लिए. So, how do we overcome hesitation and how do we start? We have to brace ourselves, we have to get the basics right, we have to choose wisely whenever we are starting, choose the right patient, the right intraocular lens calculation formulae, the right lens which is tailor made for that patient's need. So, first things first, at Deepa very nicely pointed out that we have to make our biometry as accurate as possible, and that is what we all should be doing. It has to be done on a pristine, untouched cornea. Good idea to have keratometry from two machines, the AutoK and the optical biometers are good enough. As we discussed, that optical is ideal, but many a times when optical is not working fine, you have a dense cataract, immersion is good. I think contact is something which we can leave back, and immersion is something which is still very much acceptable. We have to look at the angle alpha and angle kappa. As a mandate, I do OCT for all my patients, which can detect sometimes a subtle epiretinal membrane or a VMT, which could be missed on a clinical examination, because last thing you would like, you've implanted a multifocal lens and patients comes back with a retinal problem. Now, we have a lot of patients who have ocular surface disorder, and again, patients with a multifocal lens with a dry eye can come back with khujli pani even though he's reading 6 by 6 and N6. So, to avoid these patients of MGD and ocular surface disorder, please give them a lot of hot compresses, lubricate them nicely. A very good idea to repeat biometry after you have tackled the dry eye, and you'll see a lot of differences in the measurement, especially if you are putting a toric intraocular lens. Now, once you have chosen the intraocular intraocular lens calculation formula, very, very important to choose your patient wisely, because what you need to know is to have a happy patient. Many a times, the younger patients may be difficult to please. Again, when we talk about genders, males are difficult to please. You have to look whether you're dealing with a unilateral cataract or a bilateral cataract. Is it a myope patient or a hyperopes? Hyperopes are usually a safer bet. And again, look in depth into the occupation and the profession of the patient. Avoid a patient who's going to be fussy, who has retinal problems and has a bad ocular surface. Very important to prepare your patients preoperatively with a thorough discussion. Warn them about the contrast, glare, halos. Tell them and counsel them that they have to get operated both the eyes in a short gap for a better neuroadaptation. Tell them all the pros and cons. Tell them that they should not be comparing the two eyes, because that is where the problems come in. Do not overpromise and give them sufficient preoperative chair time so that you can avoid the post-operative chair time. And very importantly, discuss the cost factor, which has to be clarified pre-operatively. Now, many a times we have these enthusiastic counselors who go out of their way and use sentences like freedom from glasses, कि आपको चश्मा बिल्कुल नहीं लगेगा, बिल्कुल हट जाएगा. So you have to counsel your counselors that they have to use the words like reduce dependency on glasses and increase range of vision, rather than telling them that इससे चश्मा आपका बिल्कुल हट जाएगा. So once you have counseled the patient, you have done your biometry, you have to choose the appropriate formula. What I usually do is use the Barrett formula for my all calculations. Maybe going for a first myope or a e-metrope, depending on which lens you're opting for. Talk to the company guy, they'll guide you which lens, which power you have to opt for. If you're planning for an advanced monofocal, maybe a slight myopic shift in the second eye when you're planning, and definitely a very low threshold for toric lenses, especially you are going in for these advanced lenses. I think this is unsaid that you have to be proficient with your phaco, have a very good centered capsulorhexis, and remove all the viscoelastic from under the intraocular lens to prevent any kind of rotation with these premium lenses. So we'll quickly run through a few examples. Now, this was a 32 years old male traumatic cataract, a sales representative who wanted a good range of vision. So I implanted a Vivity EDOF lens, and patient is happy with 6 by 6 and N8 vision. On the other hand, this was a 45 years old home baker who had bilateral posterior subcapsular cataract, who did not drive. So I implanted a Synergy extended range of vision lens in this patient with 6 by 6 and N6 vision post-operatively. Now, this was an interesting patient, 67 years old, retired IS officer, whose brother had a trifocal lenses, was deeply disturbed by glare and halos. The lady loved to drive and wanted less dependency on glasses, so I implanted a pure C toric in one eye and a non-toric in the other eye, and patient is very happy, distance 6 by 6, drives comfortably, plays bridge without glasses, and reads with a little aid for any kind of book reading. Now, the last example, this was 68 years old female, retired school principal who loved to drive. So I implanted a trifocal lens. Initially, patient did complain of glare and halos, which settled over a 3 months period, and now she's very happy. Now, with these EDOF lenses, many a times you have patients whom you have operated many years back and you have implanted a monofocal lenses. Now, if they want a little better quality of lens and little better range of vision, I think EDOF lenses are something that you can implant in the other eye without too much compromise of the difference in the binocularity in that such a patient. So again, in this patient who had an accuracy of IQ in 2016, I implanted a Vivity lens, and patient is very happy using GPS without glasses, drives comfortably. These EDOF lenses, I just wanted to put in a word that these are very forgiving lenses, though there is loss of contrast, but they have very good defocus curve and a landing zone. But most importantly, we have to know when we have to say no to these premium lenses. Patients who have retinal problems, advanced glaucomas, large angle alpha and kappa, bad ocular surface, and a very, very fussy patient. So I think take home message would be that we should not be hesitating from implanting these lenses in our patients. We should be ready to take the plunge. Do a good biometry, a good surgery, choose your patients wisely, and choose your lens wisely. Thank you.
Thanks, Parul. Any questions? I think those are wonderful summarization. And the most important part, I think, is the proper counseling and setting the expectations of the patient. So that has been very. Just,
No, with the newer lenses, EDOF generally not. So I have a little higher threshold of putting these lenses because they have a central ring which is much more accommodating and a larger landing zone. So pretty good.